All right, I think we will slowly start for this new Australian neonatal webinars. Thanks all for joining again. Today it is my pleasure to introduce Professor Graeme Polglase. He is a fetal and neonatal physiologist from the Hudson Institute and Ritchie Centre in Melbourne, and his research already for decades is exploring the details within the transition from fetus to newborn, whether this is respiratory, cardiovascular, but also, of course, at the end of some of our goals. And today he's going to talk about how this support, what we do during transition from respiratory strategies and cardiovascular, can affect preterm brain and maybe preterm brain damage. So, Graeme, over to you.
Thanks very much, Kurt, and it's a real delight to be able to present to this group today. I wanted to start by acknowledging the Bunurong people of the Kulin Nation as the traditional owners and custodians of the land where the majority of this work was done, and pay respects to their elders past and present. So I just wanted to acknowledge a few conflicts of interest. Firstly, I have none. And secondly, I'm a content expert for ILCOR on resuscitation in the newborn committee, but I'll be presenting work on preclinical and clinical trials, but the interpretation is my own and may not reflect current guidelines. Is there an orange, yellow line on the screen? That's weird. I'll just move on.
I'll see it too, Graeme. I'll see if I can get rid of it.
Is it my end or?
I think you scribbled on it, yes.
Oh, I don't know how I did it. I don't know. If anyone knows how to get rid of that, that'll be good. I'll carry on with it there. Just give me a moment. So I want to talk about the context of today, which is that 13.4 million babies are born globally each year, and about 1 million of these will die, making it the most significant cause of neonatal morbidity and mortality globally. I really believe that brain injury is now the biggest problem facing us as researchers and clinicians, particularly as survival for our most youngest babies, those less than 28 weeks gestation, is increasing. And we know that about 70% of those will have neurodevelopmental challenges by school age. Today, I particularly want to focus on cerebrovascular injury, which includes intraventricular hemorrhage or IVH, because it's one of the major causes of preterm brain injury. It's very common in that extremely preterm population, affecting about a quarter, with the incidence and severity increasing with decreasing gestation. So about 70% at 23 weeks will have an IVH, where about 20% at 27 weeks. What I want to talk to you today is that the initial resuscitation at birth may be a source of preterm brain injury, and try and explain the physiology and some clinical support for it as to why we need to really improve the way we provide that initial support in the delivery room. So today I want to focus on umbilical cord management, kind of delay cord clamping and physiological-based cord clamping. I'll explain what these are in a moment. Umbilical cord milking, and then specifically different aspects of the respiratory support we provide in the delivery room. So firstly, delayed cord clamping, and I guess to provide a little bit of history, we know that from pictures of Greeks and Mayans and even Egyptians, so this is the birth of Mark Antony and Cleopatra's son, Alexander Helios, we can see that delivery and clamping on the umbilical cord was not done until after the birth of the baby, and in fact usually after the delivery of the placenta itself. There was great mystique around instructions for cutting the cord, and this is from Troja of Salerno in the 12th century, that when you cut the cord, a charm should be spoken and then wrapped with the string of an instrument that is either plucked or bowed. It really wasn't until the 17th century that the first account of early cord clamping, so before delivery of the placenta, was made. And this coincided with the emergence of male midwives, which again, males are to blame for most things in this world, and also probably more importantly, delivery in beds. So the idea of sparing the linen from the blood, they will clamp the cord early. And therefore, early and immediate cord clamping at that time was actually seen as the intervention. such was the outrage that Erasmus Darwin in 1801 wrote that another thing very injurious to the child is the tying and cutting of the navel string too soon, which should always be left till the child has not only repeatedly breathed, but till all pulsation in the cord ceases, as otherwise the child is much weaker than it ought to be, a portion of the blood being left in the placenta, which ought to have been in the child. So very profound and knowledgeable response in 1801. So what do our guidelines say? So really the guidelines haven't changed at all, actually, in the most current iteration, the 2025 ILCOR guidelines. And that is that they recommend delayed cord clamping for greater than 60 seconds for term and preterm infants not requiring immediate resuscitation at birth. And really this outcome was solidified by the study, the individual patient data meta-analysis produced by Seidler et al., showing the significant reduction in mortality for infants that underwent delayed cord clamping versus immediate cord clamping, and a very, very strong effect reduction of more than 30%. And really, our understanding of the benefits of delayed cord clamping have stemmed from this study from Alice Yao from the Karolinska Institute in 1969. And really the premise and the belief over the last couple of decades has been that for every minute that we delay cord clamping, we increase the amount of perfusion of blood from the placenta into the infant. And I don't have time to discuss this in detail today, but what I wanted to do was challenge this idea that 25 mils per kilo of blood enters the newborn over the first 3 months of delayed cord clamping, because what this study assumes is it assumes that the fetus only had about 20 mils per kilo of blood to start with. And actually, us fetal physiologists know that there is actually much more blood in the fetus than 70 mils per kilo during gestation. And actually what likely happens is that during labor, particularly as the fetus moves down the vagina and is squeezed, there's a transfer of blood from the fetus into the placenta, and birth actually normalizes that process. And there is some evidence for that, given that there's very little change in blood volume shown in trials where babies were delivered via cesarean section without labor. So really, the critical aspect here is that potentially, if this model is true, that severely hypoxic babies may require or may be born with a much lower amount of blood within them. And if we do immediate cord clamping, we may leave this baby volume replete. But we believe that this placental blood transfusion is really a fetal blood volume restoration. But really what I want to talk to you today is about what about the babies that require help at birth, and how should we manage these babies that require resuscitation? And there is a lot. So 1 in 5 of all babies born in Australia, and almost all babies less than 28 weeks, require some form of resuscitation at birth in the delivery room. So how should we manage these babies? And firstly, I want to talk to you about physiological-based cord clamping. So really, the most critical aspect to understand is that the transition at birth is a really critical period, and it's probably the greatest physiological challenge that newborn infants must overcome, because they're transitioning from a fetus to a newborn. And a successful transition requires aeration of the lungs to take over the gas exchange, role of gas exchange from the placenta. And it also involves the transition of the circulation from one predominantly placental to one that favors perfusion of the lungs to take that oxygenated blood around the body. If one or both of these fail to occur at birth, then this newborn infant will require significant support in the delivery room. So the critical aspect of all newborn transition, as well as the key aspects of newborn resuscitation guidelines, is aeration of the lung. And this is because aeration of the lung is critically dependent not only upon gas exchange, but also transitioning the pulmonary circulation. And we know this from changes that occur in pulmonary blood flow within the fetus, as shown here. It oscillates around 0, so majority of the blood actually bypasses the lungs. Here we've delivered this preterm lamb. Here we've clamped the umbilical cord. And you can see it's not until we start aerating the lung through ventilation in this instance do we get that significant rise in pulmonary blood flow. But perhaps it's easier to see this in synchrotron imaging done by Professor Stuart Hooper. And what you'll see here, this is a fetal rabbit kitten, and you'll see that there is no air in the lungs, and they're going to inject dye, and it shows you where the perfusion is. So you can see there's very little blood flow entering the lungs, and you'll see that we'll start to aerate the lungs, and with only a few short breaths, you see this massive increase in blood flow to the lungs. So again, this is telling us that aeration of the lungs is critical for increasing pulmonary blood flow at birth. So what I want to really enforce today is that the adult and fetal circulations are fundamentally different. So as you and I sit here today, blood returning from the upper and lower body all enters the right side of the heart. It's all pumped into the lungs where it is oxygenated, and then 100% of the pulmonary blood flow enters the left-hand side of the heart so that oxygen-rich blood can flow to the most important parts of the body, including the brain. The fetal circulation is not dissimilar in that its focus is to get the most oxygen-rich blood to the upper body. However, of course, the source of that oxygen-rich blood is the placenta and not the lungs. So therefore, oxygen-rich blood from the placenta flows up through the umbilical veins. It passes the first fetal shunt, the ductus venosus. It then passes through the foramen ovale, the second fetal shunt, where that oxygen-rich blood enters the left side of the heart, where it's pumped up to the upper body. Blood that does enter the right side of the heart predominantly bypasses the pulmonary circulation completely through the third fetal shunt, the ductus arteriosus. And this is because the lungs are filled with fluid, and they therefore provide a very high resistance to blood flow, pulmonary blood flow. So importantly, it's the placenta that provides the main source of left ventricular output in the fetus, and it's the lungs that provide the source of left ventricular output in the adult and newborn. So what must happen at birth is we must transition this fetal circulation very rapidly to the adult circulation in order for it to survive. So currently, we know the guidelines tell us that the way that we should be managing babies who are apneic at birth is to immediately clamp the umbilical cord, transfer these infants to a resuscitator, and stimulate them to breathe or provide respiratory support if we need them. So what does that do? And so what happens in that instance is if the baby hasn't breathed and the lungs are still filled with fluid, we've removed the low resistance placenta from the circulation, and this forces blood to flow through a high resistance lower body. This results in a rapid increase in blood pressure of about 30% within 4 heartbeats. So if you can imagine a fetal heart rate being around 120, 150, that's a very rapid increase in blood pressure over a short amount of time. Of course, we've also removed the main source of blood flow to the left side of the heart. And this, if you leave it long enough, progressively reduces cardiac output by up to 50% over the first minute. And it's not until we aerate the lungs, so we get these babies to breathe, either through stimulating them or providing respiratory support, do we reduce pulmonary vascular resistance and therefore allow blood to preferentially flow into the lungs. We restore our left ventricular output, and therefore we increase our cardiac output as shown here. So most importantly here, lung aeration is critical for increasing pulmonary blood flow, which of course restores cardiac output. If we look further at different aspects of what happens when we clamp the cord, particularly in between the time it takes us to initiate respiratory support, we can see this rapid fall in heart rate, this rapid fall in cardiac output, but we also see these rapid fluctuations in blood pressures and flows within the brain. And we know that this is really an important consideration because fluctuations in pressure and flow within the cerebral circulation are a major cause of cerebrovascular injury, particularly in our most vulnerable, extremely preterm infants. So what we did more than 10 years ago now was we thought, well, what happens if we change the order of this? What happens if we delay cord clamping until the infants are breathing before we clamp the umbilical cord, or we actually stimulate or provide that newborn resuscitation whilst they're still attached to the umbilical cord? So this is what we define as physiological-based cord clamping. Again, it's defined as delaying cord clamping until after aeration of the lung, either crying, spontaneous breathing, or providing respiratory support on the cord. And I want to emphasize this has nothing to do with time. It may take some babies a lot longer than others, and certainly we don't set a clock when we do this. We use physiological parameters to guide when we should clamp the umbilical cord. So what happens if we do that to this model? So what happens is when we provide respiratory support to the lungs, we aerate the lungs, and of course this allows the blood to flow through the lungs and the lungs to establish the source of left ventricular output. When we remove the low resistance placenta, we actually already have another alternative pathway for the lung for blood to flow, and that's for blood to flow into the lungs because it's now a low resistance sump. So then we get this huge left to right shunting across the ductus arteriosus of systemic blood flow flowing into the lungs, which again further increases our cardiac output. And importantly, this prevents any increases in blood pressure. When we, of course, remove the source of left ventricular output of the fetus placenta, we already have established the lungs at that source of left ventricular output, and therefore cardiac output is sustained throughout this cycle. So why is it so important to maintain cardiac output? It's really important because the cardiac output protects the brain, particularly from hypoxia at birth. And it does this by, and you can see here, this is cerebral oxygen delivery over a large range of blood oxygen levels. And you can see that as blood oxygen levels fall, the brain is able to maintain a constant cerebral oxygen delivery. And it does this by increasing carotid blood flow or cerebral blood flow, by increasing its cardiac output. If we've removed its ability to increase its cardiac output, then the brain is no longer able to protect itself against hypoxia. So again, this whole network is dependent upon the ability of the newborn infant to maintain its own cardiac output. And early cord clamping removes this protective mechanism. So when we look at what happens to heart rate and cardiac output, as well as blood pressures and flows to the brain, when we do aerate the lungs before we clamp the umbilical cord or physiological-based cord clamping, we can see that we prevent these rapid flows or fluctuations in blood pressure and flow. So it improves cardiovascular and cerebral circulatory stability. So is there any evidence of this clinically? And yes, there is. In a study done by Mike Myers' group over in New Zealand, they compared delayed cord clamping with immediate cord clamping, and then they subdivided that group into babies that were breathing during delayed cord clamping versus those that were not breathing. And what they found that those babies that were not breathing were more likely to have a severe intraventricular hemorrhage. So much greater rates of IVH in those babies that were not breathing compared to those that were breathing. And there is a lot of anecdotal evidence. Again, a number of trials have shown that delayed cord clamping in of itself, so this doesn't specifically look at lung aeration per se. The assumption is that if you delay cord clamping for a period of time, you give the babies more time to breathe. You can see a significant reduction in IVH for those babies that underwent delayed cord clamping versus those that not, although a more recent systematic review did not show the same as strong a relationship. So this is what it looks like in practice. So this is a study called Baby Duck, which is led by Doug Blank and Shiraz Badruddin. And this is showing how it works. This initially is a vigorous baby. You can see that the pediatricians are scrubbed into the field. You can see the aura of amazement and light around the obstetrician's hands. And you'll see that this baby is delivered. We try and get a heart rate as soon as possible. But the baby's crying and vigorous, so it's aerating its lungs. It's undergoing this transition in of itself. And after a period of time, the umbilical cord was clamped once a stable heart rate was determined. So this is probably the babies that are more important. And this is a baby that is born initially going okay. Again, we've got the pediatricians scrubbed into the field. This is just a normal mat with a warming pad underneath it. Ultrasound was used to get the heart rate. It's actually an incredibly quick way to obtain newborn heart rate. You can see that initially this baby is vigorous. You can see the umbilical cord is tangled, so it was repositioned. But you'll see that the baby then becomes apneic, it becomes floppy, and it becomes non-responsive to vigorous stimulation. So at this stage, the guidelines will tell you that you're meant to clamp the umbilical cord and remove this baby for resuscitation at a resuscitaire. In this trial, the respiratory support was provided on the umbilical cord. You can see that the breast will be provided. A respiratory function monitor was used to measure exhaled CO2 to ensure that we're getting adequate lung exchange, gas exchange. And you can see that we obtain CO2 within the third breath. So you can see that the baby begins to cry, the tone improves, and importantly, it's had the benefits of being on the placenta or throughout this whole period of time. So another benefit of physiological-based cord clamping is its effects on oxygenation at delivery. And one of the things that struck us as physiologists was these oxygenation curves, both systemic and cerebral, developed by Jennifer Dawson and Gerhard Pichler back in early 2010 and 2013. And what this showed us that the normal, in vigorous, normal, healthy babies, that oxygen saturation was about 60% for only half of those babies. And this meant that half of the babies had an oxygen saturation that is much lower than what it was in the fetus. So why are these babies becoming so hypoxic? And then, of course, you realize that all of the babies that were in this study actually underwent immediate cord clamping. So when we looked at our lambs, on the top you can see cerebral oxygenation and you can see systemic oxygenation. These are our fetal values. When we clamp the umbilical cord, you can see this rapid fall in both cerebral and systemic oxygenation. And again, it's not until we initiate respiratory support do we again start to see those parameters increase again. However, when we provided respiratory support on the cord or waited for these preterm lambs to breathe spontaneously, you can see that we prevented any period of hypoxia whatsoever. When we collated this into the entire study, you can see that lambs that underwent immediate cord clamping had this rapid fall in both systemic and cerebral oxygen, and it wasn't until we provided respiratory support did that be restored. And again, when they were provided respiratory support on the cord, that did not happen. And this is really, really important. And if you take only one thing away from today's talk, it is that hypoxia is your enemy. And it's your enemy because in the fetus, hypoxia inhibits breathing. And it does this very, very profoundly. This is a graph of respiratory breaths in the fetus and exposed to a period of hypoxia. And you can see that during this period of hypoxia, the fetus stops breathing. And it does this because the lungs play no role in gas exchange. So it's not a useful organ. So it shuts off that respiratory drive to preserve oxygen consumption. And this is a neuronal pathway. It's done in the lateral pons. So if you remove the lateral pons from these studies, you actually prevent that response from happening. So this is a hardwired neurological response that takes days to weeks to remove once the fetus is born. So we need to think about the newborn infant actually as an exteriorized fetus because it won't breathe spontaneously if it is hypoxic because it is hardwired to be inhibited by hypoxia. So preventing hypoxia is certainly the key to newborn resuscitation. Again, is there evidence for this? And again, yes, there is. So this was a study done in a resource limited setting in rural Tanzania. And what this study found was that And again, the context is important. There's only one attending. The baby is born. If it's not breathing, they clamp the cord immediately. They place the baby in the corner. They go back and look after mum because mum is the most important person in that room. And of course, if the baby's not breathing, it then will become progressively more hypoxic and then die. If once they delayed umbilical cord clamping until after these babies were breathing, and then once they were breathing well, place them in the corner, they're actually able to reduce mortality by 20% by every 10 seconds delay after those babies have started breathing. So this is really a profound difference. And this has also been reflected in a recent IPD comparing different durations of respiratory support. And you can see it's only a long referral, and this includes physiological-based cord clamping. So studies when they actually waited until lung aeration had occurred before they clamped the cord. You can see a 70% reduction in mortality if babies were delayed for extended periods or until the breathing had occurred. And importantly, 3 of the 5 trials in this long deferral group were done in low and middle income settings, so in India. So again, showing that this is a really critical component of newborn resuscitation. I want to quickly talk about umbilical cord milking. This is kind of a fad that crept in about 10 years ago. And actually, it's not a new thing. Aristotle in 350 BC stated that frequently the child appears to be born dead when it is feeble and when, before the tying of the cord, a flux of blood occurs into the cord adjacent parts. Some nurses who have already acquired skill squeeze the blood back out of the cord, so milk, into the child's body, and at once the baby who had previously been as of drained of blood comes to life again. So 350 BC, this was written. So this is a study conducted by Dr. Doug Blank here at Monash Newborn during his PhD. And what I want you to show is these are the effects, the physiological effects of umbilical cord milking. And this is blood pressure and blood flow to the brain. And this is a lamb that is not breathing. And you can see that with every milk of this to this preterm lamb, we get these massive increase in blood pressure and flow to the brain. So we published this study, and this is a graphical representation of that. And we said that this is a particular concern because these large swings in pressures and flows are potentially injurious and certainly increase the risk of cerebrovascular injury or IVH in preterm infants, particularly if they have an immature cerebral circulation, so particularly the extremely preterm infants. Unfortunately, a trial was undertaken in that same population, and that trial showed a significant increase, so a 4-fold higher rate of severe grade 3 and 4 IVH in babies born less than 20 weeks of gestation. It has been shown to be safer in older preterm infants and term infants. So why is it safer in those older infants? This actually generated a huge amount of media worldwide. So we then looked at why it is safer at newborn infants, and potentially the reason is in older preterm infants or those that have aerated their lungs beforehand, they've actually undergone their transition beforehand. So this is showing that when we aerate the lungs before we perform umbilical cord milking, you can see that we actually reduce these fluctuations in pressure and flow to the brain because this blood is preferentially flowing through the lungs and not straight up to the cerebral circulation. So this is showing the comparison of an aerated lung where milk has been done versus a non-aerated. And you can see quite clearly that it prevents these fluctuations in blood pressures and flows. So again, the likely reason that we see this increased risk of IVH in extremely preterm infants is because it simply takes them much longer to aerate their lungs. And therefore, when we umbilical cord milk, we're exposing their brains directly to these high pressures and flows. And therefore, again, delaying umbilical cord milking or aerating the lung prior to umbilical cord milking may reduce this risk. So in terms of the summary of the umbilical cord management, we know that clamping on the umbilical cord early can cause fluctuations to arterial pressure and cerebral blood flow. Delaying the cord clamping until after aeration of the lung stabilizes cerebral pressures and flows and potentially reduces cerebrovascular injury. Umbilical cord milking should be avoided in extremely preterm infants because of the increased risk of cerebrovascular injury, and aerating the lung prior to umbilical cord milking likely reduces this risk. And I just wanted to go back to Erasmus Darwin in 1801, who actually said this very same thing, that we should wait to clamp the cord until the child has not only repeatedly breathed. So it's taken us 220 years to actually adopt what Erasmus Darwin's postulated in 1801. So finally, I wanted to talk a bit about respiratory support in the delivery room. And we know this is a lot. So 19% of all infants require some assistance at birth. About 39% of those will require PPV in the delivery room. And about 97% of infants less than 32 weeks will receive IPPV or CPAP at some stage for more than 4 hours. We give it a lot. So this is from the neonatal network data, saying that babies less than 32 weeks of gestation receive 1.5 million hours of CPAP and over 300,000 hours of IPPV. This does not include high flow. And this is around about 6 days each. If you look at the babies less than 28 weeks, this number goes up to around about 12 days of respiratory support per baby. And we've known for a long time that there is a strong link between long-term respiratory support and brain injury. This is true for whether you're a newborn baby, a child, or an adult. And we know, and this is data showing, that the duration of mechanical ventilation increases your odds ratio in babies for a cystic periventricular leukomalacia, so old type of brain injury. But you can see as only 24 hours is enough to cause about a 3 to 4-fold increased risk, and you're getting more than a 10 to 15% increase over 7 days of respiratory support. But what about the immediate respiratory support in the delivery room, and why is this important? So actually, the way we provide respiratory support in the delivery room is the least controlled of any time a newborn infant will have. It's provided using handheld devices, typically the teepees in Australia, but other self-inflating bags. It has a set inflation pressure. Often some of the devices, particularly these devices, don't provide positive end expiratory pressure. And importantly, we don't know what sort of volumes we are providing to the newborn infant. Again, work by Stuart Hooper really showed us the critical importance of positive end expiratory pressure in establishing functional residual capacity at birth. And this is a preterm rabbit kitten being provided with positive pressure ventilation with no PEEP. And you can see that the fluid in the lungs flows back into the airways, and it takes a very long time to establish aeration of the alveoli and therefore gas exchange. And you can see very clearly that with the provision of PEEP, we're able to hold that lung liquid or prevent it from flowing back into the airways at the end of each breath, and we're more rapidly able to recruit the lung. And really, it was these videos that helped really establish positive end expiratory pressure to be used for newborn resuscitation. We know that it improves lung volume, reduces oxygen requirements, and also the incidence of apnea in preterm infants with RDS. The current treatment recommendation for ANSCOR is that we use 5 to 8 centimeters of PEEP during newborn resuscitation. And we also know that higher than that may impede pulmonary blood flow. Importantly, there is not a lot of data on term infants, and actually using higher PEEP in term infants, some recent studies have shown may actually cause some harm. A really fantastic way of inflating the lungs is via a sustained inflation, and a large number of animal studies, of which I was involved with, demonstrated that a sustained inflation of around about 20 seconds was able to rapidly recruit the preterm lung. It improves the uniformity of lung aeration, and it improves lung compliance and respiratory status, so making it very much easier to provide respiratory support, in this instance to rabbit kittens, but also to preterm lambs. I'll just show that again, how rapidly it does aerate and uniformly aerate the lungs. However, of course, this did not play out in clinical trials, and really this was because the clinical trials used a face mask or a T-piece device to provide sustained inflation, whereas the animal studies, these animals were actually intubated. And this really provided the importance of the glottis actually blocking our ability to provide respiratory support and a sustained inflation. And this trial showed us that an increased risk of IVH, more than almost double, I guess, in the trial, the Italian group. And the most recent SAIL group actually showed an increase of mortality in infants that received a sustained inflation compared to those that did not. The Cochrane review shown here shows a non-significant but an increased risk of IVH in infants that received a sustained inflation compared to those that didn't. So the current newborn recommendation is against the use of initial sustained inflation of greater than 5 seconds. And this is because the European resuscitation guidelines have 5-second sustained inflations in their recommendations, but it can be considered in a research setting, and there's no evidence either way for late preterm or term infants for the use of a sustained inflation. I think the most important aspect is what tidal volume we're providing during the initial respiratory support. And this is a study done at the Royal Women's Hospital by George Schmalzer. These are 20 individual babies, and this is the tidal volume that was provided to each of these babies. And the red shaded shows the typical safe band recommended for newborn resuscitation. And you can see that 80% of these babies received much higher tidal volumes than what is recommended as the highest of 8. And you can see some babies even received more than 30 mils per kilo of tidal volume being provided with a set pressure. So when I worked with Alan Jobe and his colleagues in Jane Pillow in Perth, we undertook a number of studies investigating the effects of tidal volume and the initial respiratory support on lung inflammation and injury. And this group in white is a control group, and these 3 groups are groups that received respiratory support for increased durations of time. I just want you to concentrate on this shaded grey area because this group only received positive pressure ventilation for 15 minutes. And you can see that that 15 minutes was enough to significantly increase protein, neutrophils, and monocyte numbers within the lung, and also create a profound inflammatory response as shown by a significant increase in cytokines. We then undertook another study looking at, okay, this is going on in the lungs, what about external to the lungs? And again, what we then did was we looked in the lung and also within the liver, and we found that inflammation in the liver was significantly increased with only 15 minutes of respiratory support. And again, some inflammatory mediators were again increased with just 15 minutes. And you can see that the longer we provided respiratory support, the greater that inflammatory response was. So this really told us that the initial respiratory support is enough to induce a profound systemic inflammatory cascade, and only 15 minutes is enough. And so is there any evidence of this clinically? And actually there is some. So these are studies done by Carl Bose and Bora over in Europe, and they actually looked at systemic inflammatory cytokines, particularly IL-6, IL-10, just before respiratory support, and then 2 hours after respiratory support. And you can see this significant increase in IL-8, IL-10, interleukin-1 beta, and TNF-alpha, almost a 10-fold increase in these pro-inflammatory cytokines and reduction in this anti-inflammatory cytokine with only 2 hours of respiratory support in preterm babies. So this is a pretty profound systemic inflammatory cascade. So then what's happening within the brain? So with my colleague Susie Miller and my PhD student Samantha Barton, we looked at the consequences of different tidal volumes during the initial respiratory support on brain inflammation and injury. And what we found was when we did a protective tidal volume, so around 5 to 7 mils per kilo, versus an injurious, which is around about 10 mils per kilo, we can see a significant increase compared to unventilated controls in black of inflammatory cells, so lipid peroxidation, as well as microglia within the subcortical and periventricular white matter. And you can see this accumulation increase in inflammatory cells, and also this injury is starting to occur within the brain. So this patchiness representing kind of like a diffuse white matter injury. When we provided a protective respiratory support, so a low tidal volume, it actually was able to maintain carotid blood flow or cerebral blood flow at a near constant level. When we provided an injurious high tidal volume ventilation, we see that this resulted in profound fluctuations to blood flow within the brain, and this resulted in a 60% occurrence of cerebrovascular injury, so as indicated by cerebral extravasation. But this did not occur in those lambs in where we provided a protective respiratory support or low tidal volume. Again, this is preterm lambs. Is evidence this clinically? Yes, there is. In a clinical trial we did with George Schmalzer in Canada, we looked at babies who received a high greater than 6 mils per kilo or low less than 6 mils per kilo tidal volume during the initial resuscitation delivery room. And you can see a significantly higher rates of IVH overall, 50% compared to about 15% for those that received a lower tidal volume, but more importantly, a 20% rate of high severe IVH, so grade 4, compared to about a 5% for those that received a lower tidal volume. We undertook a meta-analysis grouping all the trials, and this wasn't specifically looking at low tidal volume. This was actually looking at the use of a respiratory function monitor to better guide tidal volume delivery. And although it wasn't significant, you can see that it almost was a significant reduction in IVH when clinicians were able to see what tidal volume they were delivering and then adjust the pressures to try and maintain a tidal volume of less than 6 mils per kilo. And again, if we look at a more recent trial undertaken by Interpass, so his group in Leiden, they show quite convincingly that if you used a respiratory function monitor during the initial respiratory support, they had a significantly lower rate of IVH of any kind, 26%, compared to 37% when a respiratory function monitor was not used. And again, if you looked at all kinds of brain injury, including periventricular leukomalacia, again, a significant reduction when a respiratory function monitor was used specifically to target a lower tidal volume. So finally, I want to finish up with oxygen, and this is kind of, I think, the new frontier. And it's new because really we know that oxygen is vital in the care of extremely preterm infants. We know that by hypoxia and hyperoxia can increase mortality as well as adverse neurological outcomes. And I believe we still do not know what is the safe amount of oxygen to use in the delivery room. The guidelines have changed from 100% to moderate, 30 to 65%, down to low, less than 30% oxygen, starting oxygen that is. But this new recommendation is a weak recommendation with very low certainty of evidence. And importantly, most of these trials were done again in the context of immediate cord clamping, not even delayed cord clamping, let alone physiological-based cord clamping. So there's very little evidence on the optimal starting FiO2. We know from the really fantastic work of Julie Uwe that targeting a saturation of 80% within 5 minutes is really the key. If babies don't reach this point, then they're at a much greater risk of IVH. And certainly she found that if we start low, as the guidelines tell us to, these babies have a much significantly decreased likelihood of reaching the target FiO2, or SpO2, I should say, at 5 minutes. Importantly, if we start with a high initial FiO2, this may be associated with reduced mortality compared to less than 30%. And this was the main finding of a recent IPD systematic review that actually said that starting in 90% or even 100% oxygen actually reduces mortality compared to the current guidelines. And Julie Uwe recently presented the most recent torpedo trial comparing 60 to 30%, which actually found no difference in IVH rates, but she did show that babies started in the low oxygen levels were less likely to reach the target point of 80% at 5 minutes. So we've been investigating the importance of and the link between cerebrovascular injury and the initial resuscitation, the initial oxygen at birth. And this is showing what happens to the cerebral circulation if you resuscitate in 30% oxygen, and you can see this massive perfusion, this massive vasodilation of the cerebral circulation. This is a preterm lamb, and you compare that to when we provided respiratory support with 100% oxygen, and you can see that actually there's very little amount of perfusion of the brain. And this is purely because of this adaptive response I told you earlier. When they're hypoxic, the brain vasodilates to increase oxygen delivery to the brain. When there's enough oxygen being provided to the brain, it doesn't need to vasodilate. And so critically, in this brain, where we've provided low oxygen, so it's a hypoxic environment, any resuscitation we provide that causes fluctuations to pressures and flows on this vasodilated circuit will increase the risk of cerebrovascular injury and IVH, because it's incredibly susceptible to it, whereas a very well oxygenated newborn infant will be protected because the cerebral circulation is vasoconstricted. So again, preventing hypoxia is the key. And I wanted to acknowledge Flora Wong and my PhD student, Zoe Johnson, who's working on these studies currently with us. So what we've done over the last few years, we've really refined this pathway of how respiratory support in the delivery room can lead to white matter injury and cerebrovascular injury. And it does this through two major pathways. This hemodynamic pathway, where respiratory support causes fluctuations to pressures and flows, resulting in most likely cerebrovascular injury. And again, the initiation of respiratory support, if done in an injurious way, initiates a profound pulmonary inflammatory cascade, which becomes systemic, resulting in a profound inflammatory cascade within the brain itself. And what I've hoped to show you today is that individual components of that respiratory support in the delivery room, such as the way we provide umbilical cord management, tidal volume, PEEP, oxygen, as well as sustained inflations, can all impact on these two pathways, increasing the risk of inflammation, injury, and cerebrovascular damage within the brain, particularly the extremely preterm brain. So in summary of respiratory support, it does increase pulmonary and systemic inflammation with downstream consequences to other organs. There's now a very strong link between the initial respiratory support and subsequent brain inflammation and injury. Improving the way we provide that respiratory support can reduce brain injury, and we're actually undergoing a trial now in Canada where we're putting preterm infants directly on a ventilator in volume guarantee mode in the delivery room to remove this variability in the way we provide respiratory support. Oxygen is probably a critical component of cerebrovascular injury, much more than we previously thought. And again, preventing hypoxia is certainly the key. So I guess the take-home messages for everything is birth is a really complex physiological process. As young neonatologists, I implore you to think of a newborn baby as an exteriorized fetus, not as a small adult or a child, because its physiology is very different to that of an adult. Aeration of the lung is the key to a successful transition at birth, and certainly all efforts initially should be focused on getting the baby to breathe and making sure we aerate the lung. We believe that doing that before we clamp the cord will improve cardiac stability and reduce cerebrovascular instability. Umbilical cord milking shouldn't be done for extremely preterm infants, but again, that may be dependent upon the physiology of the newborn. And really, our focus should be on optimizing respiratory support in the delivery room to aerate the lung, but prevent adverse downstream consequences. I'd like to acknowledge my team and really thank you for this opportunity to present to you. Thanks very much.
Well, thanks, Graeme. Fantastic. Again, lots of physiology where you took us to the essence and the questions we have, during that complex period of transitions from a fetus to a newborn. Cord management, respiratory support, oxygen, having all their individual facts. I really like that summary slide you did at the end, and some are contradictory even to each other, or complementary, however you want to call it. You told us to do aeration first, although you didn't tell us how to look for that as a clinician, so that's going to be a question. And then you told us to prevent hypoxia, which we do measure and can measure during resuscitation. So now this is great overview showing a really deep insight from the physiologists telling us clinicians of what to look for, and then particularly how to manage that in our complex and variable situations in our prems. I'm going to go to some questions. I saw Kumar has some questions about that poor outcome, particularly with sustained inflation, because if aeration is the key, why didn't sustained inflation work? Why did it lead to more IVH and particularly more mortality?
That's a really fantastic question, and I actually was going to talk about that in more detail. Essentially, what we know from a physiological standpoint in the fetus is that in the fetus the glottis is always closed, and it only opens when breathing or fetal breathing movements occur. And again, in the newborn infant, there's now really great data coming out of animal models and a recent ultrasound study done from Leiden, which shows that actually the glottis is closed almost all the time and only opens when the infant's breathing. And it takes a long time, for about an hour, for the glottis to remain open into what is our normal adult situation, where the glottis is open all the time and only closes when we swallow. So what happened in those studies, of course, is we didn't know that. So they tried to provide a sustained inflation through at the upper airways, and the glottis was closed. So all they ended up doing was really inflating the pharynx and providing quite a high pressure to the head, and that resulted in an increased incidence of IVH. I still believe that if you could get the sustained inflation to the lungs, which would require you intubating, unfortunately, then that actually is a beautiful way to provide, to aerate the lungs uniformly and quickly, but you can't do that in the human context. And a really classic example of when we try to translate from animals to humans, that we miss aspects of the complexity of what you guys actually do, which is using a face mask or nasal prongs or something like that.
So that's great. Maybe we're going to go back to the old-fashioned days, intubating all babies. And I really like that idea where you told us about directly on volume guaranteed from the very start and take out the humans, basically. Reza has a question which is about the FiO2 and the complex studies and the interpretation of that. How are we going to work with this? This new torpedo study showing no difference, you showing no prevent hypoxia. What do you use in the centers you work with?
So our centers follow the guidelines, of course. Look, I think the world is moving, and there's plenty of studies to show that actually high oxygen is better for extremely preterm infants, at least initially. And with a caveat that there must be quite rapid titration based on the SpO2 targeting. The torpedo trial's fascinating because, as you know, they compared 60% versus 30%, but almost every baby was in 60% within the first 1 to 2 minutes. And most babies did not reach their oxygen saturation targets, which meant they needed more oxygen. But the trial limited the upper oxygen to 60% as part of the consent process. So actually, whilst this trial showed no difference between 60 and 30%, the trial told us that you need to use more oxygen for these extremely preterm infants. And there's certainly some nice evidence, again, coming out of Leiden, where if you provide a higher oxygen, they use 90% to 100% in all of their extremely preterm infants. They establish much greater respiratory drive. They're able to reduce the amount of mechanical ventilation, a small reduction in BPD by using higher oxygen. Again, the caveat being that you start high and then wean rather than starting low and then trying to go up.
So no particular answer there yet, but the physiologists are going to puzzle this out for us a little bit deeper, I think. Yunyi has a question about the role of end-tidal CO2 monitoring in the delivery room. Does that
Yeah.
help? Can we then evaluate that aeration, which he says so important?
Yeah, it's fantastic. I think it's something, a device or tool that is underutilized. It's really the only tool that clinicians have to know that you're aerating the lung. Obviously, if you're getting a decent CO2 out, you have gas exchange occurring. So it's really a fantastic device. Doug Blank also did some studies looking at the use of the pedicap and also showed that when the pedicap changes color, it correlated with an increase in pulmonary blood flow as well, which again is determined upon lung aeration in of itself. So I think end-tidal CO2 is important, and I think it's going to be a critical tool in delivery rooms of the future. Another cool way to do it is through lung ultrasound, but that's a little bit more complex to do in the delivery rooms.
Well, yeah, I guess if we want the best care for these babies, we probably have to explore some new tools, including ultrasound. You showed, how ultrasound can detect heart rate very quickly and effectively, and you can use that same probe on the lungs. So I do think that might be something in the future. A question about the differences in cord milking, in delayed cord clamping kind of thing, and cord milking in relation to it. I know your group has presented a way which it might be safe. Can you explore or tell us about it?
Yeah, so I guess, and thanks for the question. The short answer is that there's been no studies comparing different types of umbilical cord milking strategies with each other. And certainly the main group that does cut cord milking is the Japanese, and the Japanese are really good at it. They do it routinely for almost every extremely preterm infant. So this involves clamping the cord, removing the baby, and then milking, usually when it hits the resuscitator. The caveat to that is that there's quite a bit of time between when they actually milk and from when they clamp the cord. So that extra time is given those babies time to start breathing and, aerate their lungs. So the process of clamping, cutting, moving, and then milking actually is probably a better option than milking whilst it's on the cord, specifically if the babies are not breathing. But certainly to emphasize that any umbilical cord milking strategy is not recommended by ILCOR for babies less than 28 weeks.
Yeah. I have a bit of a mechanical question about that. You showed that, first of all, immediate cord clamping gives this, rapid rise and changes, and then there was cord milking, which gives this intermittent sort of rise and fall. How come the IVH is not there at 1 hour of age? How come it takes like 12 hours or 24 hours?
Very good question. So I think what we see in our animal studies as it originally or initially causes small microbleeds, so extravascular leakage, small bleeds, and that takes time for you to be able to detect them clinically, particularly with an ultrasound. So I think, and what's been interesting actually of late, and there was a recent study came out, I can't remember who did it, that actually showed that whereas we used to believe that most of the IVH occurred within the first 24 hours, that's now shifting to beyond the first 2 days now. And potentially that is because we're looking after babies better in the delivery room. Almost all babies are now getting delayed cord clamping. So potentially we are actually removing that initial hemorrhages, those early ones. But the delayed ones are occurring due to different reasons.
Yeah, sustained damage can give ongoing inflammation, ongoing sort of problems. It's 2:00. Thank you everybody for attending. Thank you, Graeme. This was an awesome talk. Thank you so much. And I think we're back next week with another webinar. So thanks all for attending, and thank you so much, Graeme, for presenting.
Thank you for having me.
Recording stopped.
Thanks, Kurt. Hope that was all right.
Oh no, loved it, man. That overview is for us is good because I know what you just showed is literally a decade of work, with lots and lots and lots of studies to find every little question to each other. But your videos were awesome with that, the chords and then woof, woof.
Yeah.
That's amazing though. So you really think that's getting later now? All that the bleeds because we had a couple of them which are late. I look early, very early. Look, I do the whole resuscitation, etc. I look at the heart and I look at the head before sort of I leave, the whole baby for the rest of, and then we do another scan at day 3.
Yeah.
So this information must have come from the Japanese who do, endless amount of ultrasounds and seeing a change. So that's an interesting information. I'll look for that.
Yeah, because we used to think that almost 50% of the bleeds occurred within the first 24 hours.
Yeah.
Now I think it's around 30% in the first 48 hours was what the recent big meta-analysis showed.
All right. It's not my experience, but that'd be interesting to look at that. But because you have to do so many scans to get that information, which is the opposite what we would recommend in particularly the European centres and the American centres. I think in the Australian as well to not touch the baby every day.
Yeah.
With this kind of information. So I think that must be from the Japanese then.
Well, it's interesting because we have this debate at Monash Newborn, and a few of the clinicians say, well, look, we don't see these hemorrhages early. And then Flora kind of says, but we don't look for them early. We don't scan until 72 hours now. So we wouldn't know. Yeah. And I think that's the problem with all of these studies is they don't know when they're occurring. It's really the time they're being picked up rather than when they happen. So
that study of Flora looking at that perfusion in the brain, unbelievable.
That's very cool.
But and that's good, how oxygen works in that context versus how much blood you want to go there and be stable is actually, those are two components which might be way more important than we think. But all right.
Yeah, that's very cool.
All right, well, get better. And
yeah, you too.
We'll chat soon.
Yeah, thanks, mate. Cheers.
Thank you.
Bye.